very quickly. Well, we have them live. Then I'm going to present very shortly here the case history. So we're going to be talking about a 75-year-old female. You see the cardiac history, a recent presentation with chest pain, a non-STEMI due to a lesion in the right coronary, and then she has also additional disease in the left coronary. We try also to get the case prepared as we did with the previous one with CT, but the CT was not available. For that reason, we will not have the pre-planning with CT. You see the risk factors on the slide, and again, the previous PCI for the culprit image in the right corner. This is the pictures from the first procedure. You see here a tight lesion in the distal right coronary artery, a very severely calcified vessel, and these are the shots of the left system. You see there is mild disease in the distal left main, and you see again, difficult to interpret the angiogram. There are many branches here, but I think we have a nice cranial shot here showing basically distal left main stenosis at the level of, it's a bifurcation of the left main, but a very close diagonal branch which bifurcates, so very large mass territory subtended by that, and again, a second lesion in the mid segment of the LAD. This was the procedure, was successful with successful recanalization with one stent in the distal right coronary artery, and basically we'll be focusing today on the left coronary system, where you have seen here that there is a very tight stenosis at the level of the mid-LAD, moderate to severe left main stenosis. You see there the IVUS that were done for diagnostic purposes. I cannot read what is in the screenshot of IVUS. We will see that certainly live and understand what are the lumen areas, and a very tight lesion in a subsegment of that first diagonal branch. So now we're going to discuss basically the strategy with the operators, but of course we need to think about how we would approach the left main bifurcation, if we need to do something about the mid-LAD, and of course there is an open question if someone would intervene in that sub-branch of the first diagonal branch.
Thank you very much. If we could please be connected to Dr. Ali Masood in the Specialized Medical Center now. Can we please be connected? Dr. Ali Masood, can you connect us please to the technical team there? Ali, can you hear us? We can see your lab now. Dr. Masood, can you hear us?
Yeah.
Dr. Ali? Hello, can you hear us?
We can hear you. Can you hear us?
Yes, we can hear you now. Good. We apologize first for the delay, but it was really beyond our control. I understand you have finished the case, but can you please show us what you did and walk us through it step by step, stopping at areas where we can maybe feel it's important that we discuss?
Sure. And you've seen the case presentation. I think did Carlos show the slides already?
We can see the IVUS now.
Oh no, I mean, and the angiogram as well.
Did you get some of the clinical data? Was there the slides presented?
Your voice keeps coming and going. Really can't hear you very clearly.
Dr. Khalid?
Yes, that's better.
And can you see the angiogram on screen and the IVUS on screen?
Yes, we can see the IVUS call. We see the IVUS and we see you and we see a screenshot of the angiogram.
Brilliant.
Okay, good.
And you've gone through the setup slides, Carlos, clinical history?
Yes, we already discussed the clinical history. We saw the PCI of the right coronary and we showed the diagnostic pictures of the left. So please tell us what you have done after that.
So let me just start by thanking Optima and the National Heart Forum for giving us the chance to be part of the program and present this case. We understand there was like delay in the timing, so the patient was 75 years old. She could not stay still on the bed, so we finished the case, and patient, she was fine at the end of the procedure, but because of her age and back pain, she could not wait. I would like, before we go through our procedure, to thank Dr. Combs Huntry for being with us, and we learn a lot, and we have lots of learnings in this case, and I'd like to thank my cath lab team an radiographer for being with us during this case. And without further delay, I will ask Dr. Khan to go through the steps of the procedures, and then I'll take you through the IVUS results as well.
So a couple of things, Carlos. What's our time slot? And do you want to have a discussion in the auditorium about what we should do or what things you want us to, what you're going to anticipate with this case, and what were the thoughts of the panel in terms of how you would approach this case?
Could you repeat that? We didn't quite catch what you said.
Okay, so this is the setup shot. We tried to get a 7 French guide in, but the lady was quite small, and we got a 6 French guide in from the right radial. And what you'll see on the angiogram is the setup shots, which is as we expected from the diagnostic angiogram.
Yeah, we have Irish translation in case we need it, but I think that the question to the panel was, there was a distal left main lesion, mid LAD lesion, and the question is how would you have approached this particular case?
That's correct.
I think since the lesion is diffuse disease, so with the new evidence to support the drug-eluting balloon for the distal after the physical preparation for the long shaft LAD disease to prepare it well, then followed by drug-coated balloon, including the side branch if it is needed. For the proximal towards the left main, probably we may need lean towards the stenting, this one. So the bifurcation part, probably we deal with it according to the IVUS result.
Okay. Very good. So DCB for the mid LAD, stand for the proximal. Any different approach from any other member of the panel?
Yeah, I will, because you posted the question for diagonal. I will not chase diagonal. I will go straight to the LAD and circ and an NC balloon after imaging, and I will plan it after imaging. What modification do I need? I think it's calcified because of the age, because of the appearance on the angiogram, but it will be professional and it will be stenting.
Okay, Colm, I think we are. Go ahead, please. Go ahead.
I don't know if you can appreciate that. There is a lesion in the trifurcate which is quite tight. But anyway, I'll tell you what we did. The CT scan, which you don't have access to, was non-diagnostic for the purpose of your analysis, Carlos, but it did show an eccentric calcified lesion in the proximal LAD at the point where the IVUS the last time did not cross. So the last time the patient was in the cath lab, was a diagnostic procedure done, and the IVUS would not cross. About 1.5 centimeters from the septal branch, there is an eccentric calcified lesion that the IVUS would not cross. And we saw that on the CT scan. So that did give us some information up front. And in terms of what we did a stent boost with a balloon expanded in that area, which gives you an idea of the eccentric nature of the calcification. There's not as much wire bias as you might have, so the balloon did expand, and maybe we'll flip to the IVUS, and Ali will describe the IVUS findings.
Yeah. So we did, the procedure was completely guided by IVUS. We did during the procedure and post-procedure. So let me just walk you through the first run of IVUS. If you can see the screen, let me just go. This is distal LAD, which we think is probably normal, relatively small, 2.5 maximum. Then you can appreciate soft atheroma starting the distal LAD, getting worse, and there is eccentric calcification and 3 to 5 at the close to the diagonal that you saw, the second diagonal, or the mid LAD diagonal. You see the tightest stenosis that involves the bifurcation of the LAD diagonal. And then there is another eccentric atheroma in the proximal LAD with heavy burden of soft atheromas as well, or mixed plaques. The distal left main is tight too. The minimum lumen area was 3.4. And then there is segment of the proximal mid and distal. This is mid left main, which having mild atheroma, then there is moderate, at least moderate atheroma in the ostial left main, as you can see, involving, and this, probably you can appreciate how tight is the very ostial left main. So eccentric calcification, mid and distal and proximal LAD, and tight stenosis and distal and proximal left main.
So most of the calcium was in the distal left main ostial LAD, is that correct?
No, actually, at the septal branch, just beyond the septum, here, and it's an eccentric lesion.
That's
But
the
we
point
felt
of the,
that it was,
that's the
yeah.
point of the highest calcium come, because it doesn't look so calcified from here.
Exactly. It wasn't as bad as we thought it was going to be, Carlos, and we decided that we would try an NC balloon in this area rather than a shockwave. And actually, it came up very well with the NC balloon. So that's another clear stent with the balloon expanded. There is some wire bias, but not a lot. So our impression was that the
Colin,
calcium was modified.
A quick question. A lot of operators, at least in this part of the world, when the IVUS can't pass and you've got obvious calcification on fluoroscopy and an IVUS catheter won't pass, frequently many operators will reach for rotational orbital atherectomy, in that case in a non-crossable lesion, because if the IVUS catheter doesn't pass, lithotripsy is not going to pass, and you know there's a lot of calcium there. So why did you choose an NC balloon rather than proceed with some form of atherectomy, especially since your imaging catheter did not pass initially?
It was very, very focal on the CT scan and on the IVUS, and we felt that it was a volcano IVUS, which isn't the most deliverable. We give the lesion a squeeze with a 2 balloon, and the volcano IVUS was able to go. So we think it was just signified tight disease. The calcium is eccentric. It's not very long in length, and we thought an NC balloon and with a low threshold for shockwave. And when we show the IVUS after the NC balloon inflation.
Okay, very good. So then let's proceed with the rest of the case. Colin, if you want to show us perhaps the angiograms after you place the first stent and which technique. It looks like a provisional case, but what have you opted at the end?
Yeah, well, I think the point is we'll show you the fracture on the IVUS after the NC balloon. We felt that this was extensive atheroma all the way down to the distal LAD, back to the ostium in the left main. We did pivot from a DCB strategy. We talked about that offline. With the volume of atheroma and the extent of the atheroma, we felt that stents were needed. We didn't see a good landing zone for one stent without having to go beyond that diagonal.
So you can appreciate the run of the IVUS after the NC balloon. You see the fracture of the calcium, so it was not difficult to deal with the calcium by NC balloon. That's why we did not consider using shock waves or other calcium modifying tools. Most of the calcium gets fractured with NC balloon. So you can see now that.
So this is a 3038 Onyx stent. We used it to measure. We don't. This is the manual pullback on the IVUS, so we don't have that information of lesion length, etc. So this is old school measuring. That's a 38 millimeter stent, bringing us back to the ostium, and then that's the 38 millimeter stent distally with a provisional strategy. So we inflated that. We did a little check flow to see what size of stent we needed. And interestingly, if you look at the diagonal, you can see it is compromised and pinched. And the patients did start to get symptoms at this stage related to that diagonal compromise. But we felt that rather than trying to rewire and sort it at this stage, we had to put our second stent in, optimize the stent, and then come down and deal with the diagonal. So we proceeded with a 3.5 38 millimeter, jailing the stent in the diagonal. This is an LEO 30 shot, which shows you the ostium off the left main quite well. We have our 6 French system. If we had a 7 French system, we could have done real-time IVUS guidance, but we didn't have that. So we positioned the stent, and then we potted with a 4.5 balloon. And then you can see the diagonal is compromised. We're going to have to do something with that, so we have to rewire. But we left the wire in place to keep it open, brought a second wire down to wire the diagonal. And with the second wire in the diagonal, we bring a balloon into the main vessel, and that allows us to take the jailed wire out of the diagonal safely. If there's any damage to the stent, we can deal with that with the balloon. So we took a 3.5 balloon, post-dilated. Then we took a 1.5 balloon into the diagonal and did kissing inflation with a 3.0 in the main vessel and a 1.5 in the diagonal. So, and we can show you an IVUS of that. Anybody want to do DCB in the Austin the diagonal, or do you think we're done?
Yeah, there are two relevant questions at this point. The first one is, I would love to see the IVUS post PCI because angiographically it looks like some not optimal expansion, especially at the level of the bifurcation of the left main and at the level of the second lesion. And the second question would be, yes, what to do with the second diagonal that looks pinched in this projection.
So this is the IVUS post stenting, and you can see the distal stent nicely aligned to the, so it's well opposed, well expanded. There are areas of eccentric calcium that probably pushing the stent, but otherwise you see the area here at the bifurcation with the diagonal, and otherwise most of the stented part, the stent looks okay. You see the eccentric calcium here in proximal LAD, and this is proximal LAD, left main. So okay, this is the left main, you see. So it looks like well opposed, and the left main has a 4.5 NC balloon.
Yeah, and our areas were very good. We've got an area of 8 in the LAD and 11 in the distal left main. I've just been showing you a PA cranial projection throughout the case. I don't move very much once I get started, but we did go over to an REO 30 when we were doing the NC balloon to show that the calcium was eccentric. So, Carlos, while it looks that, you know, as you point out rightly, there are several areas that look not so good on the angiogram, those are eccentric lesions. And we've got good area on IVUS, and when you go to a different projection, it doesn't look so bad. So it's just an angiographic issue rather than an area. Second issue in terms of DCB, we decided that, you know, it was interesting how the patient got quite sick when the diagonal was compromised, but tolerated all the other stuff. So we felt, having kissed and opened the struts into the diagonal, that we're not going to put a stent into that vessel. We debated about whether DCB or not, but ultimately at the end didn't.
Let me go here quickly over the panel. Who would do, who have done something different in the diagonal branch or in the main vessel?
No, I would do the same
Sorry,
thing, but
dropped
I have
out
a
in terms of
question.
sound.
My question is why angiographically the proximal LAD seems bigger than the left main. So is there any explanation for this, or from the IVUS at least?
So we were happy, like at this stage, patient pain subsided with the kissing balloon and the TKNC, and last IVUS run, we were happy with the areas of the mid proximal and left main as well with regard to the areas, and we decided just to
Stop at that stage.
stop at this stage. Yes. Any questions or comments?
Other than the diagonal, it's a second diagonal. I think most people.
I think the speaker, yeah, the speaker power.
I think most people with
No,
the
the
second
JBL speaker has stopped.
I think most people with the second diagonal would agree that the primary aim would be just to keep it open with normal TIMI 3 flow. It's not a vessel I'll go after aggressively to stent. So I think most operators would agree with what you did in rewiring it and dilating it with a balloon, just keeping it open and establishing good flow in it. My question is, after you stented back into the left main, we haven't really seen a good picture of the ostium of the ramus and the circumflex, if that needs anything done. And maybe if Dr. Naif Al-Asir or Dr. Hinde has any comments that they'd like to make.
First of all, I would think about FFR and the mid-LAD because angiographically, for me, it looks moderate in severity, regardless of the area and the IVUS. Second thing, for the diagonal, I think it's too small. to consider kissing balloon inflation at the end after provisional stenting. So I would accept this flow on the diagonal.
Okay, can you hear us, Carlos? We dropped out for a while.
Sorry, I didn't hear the question.
Very good, Colm. And Dr. Ali, is anything else that you want to show us? Do you have a different projection of the angiogram, perhaps a spider to see the other branches, the ramus and the circumflex?
Back to the conference.
It's fine. Just make it.
If we could just see the final angiogram, please, in two projections.
Just go on with the program. We can finish it.
Are you still with us?
Have you got us? I think the AV is very temperamental. Maybe we should just go on with the conference.
If you could just put on the main screen the angiograms, just the final angiogram, so we could take a look at them here, and we'll conclude the live transmission.
Dr. Khalid, what is the left main area by IFAS? At the ostium, at the mid-distal.
11 is the smallest area in the left main, and 8 at the area of the eccentric calcification in the LED. So very satisfactory areas.
What were your MLAs in the left main and the ostial LAD?
Before our final.
After stenting.
Yeah, after 11 millimeters squared in the left main and 10 in the LED.
Could we see it? Did you take a spider shot by any chance?
No, once I've flown all branches to see IVUS, it tells me whether I'm finished or not. So I don't do other angiographic views because I don't really think it helps you. This was the best view, the showing the ramus branch, and it was free of disease. The lesion was beyond the ramus, so we were certainly very pleased that we didn't have to go into that. It's very retroflex to try and treat that. There's good flow, you know, a 75-year-old lady. So we were pleased with the, because we did start at the start, talk about putting a stent in that at the start and then geeling across it in case we had trouble getting back into it, but we didn't need to.
Great, thank you very much for an elegant demonstration. I think we can move on to our, thank you very much, Dr. Masoud. Thank you, Dr. Hanratty. Thank you very much.
Thank you.